ALL Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the ALL Hub podcast. Today we'll hear from Charles Mullighan of St. Jude Children's Research Hospital in Memphis, US.
Today I'll give some comments on how advances in genomics are influencing the diagnosis and management of acute lymphoblastic leukemia. So the first question to discuss is how advances in ALL genomics are informing new treatment approaches. And I think there has been a profound shift in how we think about the management of ALL, both from the diagnostic and therapeutic perspective, because of advances in genomics. This has been particularly over the last 10 years with large-scale studies using a variety of genomic approaches, perhaps RNA sequencing being most impactful more than any others. And these approaches, both in childhood ALL as well as in adults, have shown that ALL comprises over 20 different subtypes in B-ALL, many of which were not previously recognised. And these studies have also identified the drivers underlying these new subtypes. Most of these subtypes have got distinct gene expression profiles, but the drivers can be readily identified with sequencing-based approaches, particularly RNA sequencing. Some key points are that much genomic work in cancer uses gene panel-based testing, and that perhaps is really not so suitable for ALL because we see many of the drivers are fusion oncoproteins or changes in DNA content, aneuploidy, so forth, which really are not well addressed by gene panel approaches. So the ideal approach really is an agnostic sequencing approach, such as RNA sequencing, or if that's not available, alternative approaches, methods such as capture-based sequencing that can detect RNA fusions, as well as point mutations as well. Examples of that are the Archer fusion plex and Foundation 1 heme. In the absence of any sequencing-based approaches, it's difficult to detect all subtypes of clinical relevance, but a great deal can be learned from approaches that couple conventional analysis such as cytogenetics with approaches such as FISH for rearrangements, including key targets of rearrangement in pH-like ALL, flow cytometry that can detect, for example, rearrangement of CRLF2, and some markers that are associated with some of the other subtypes, for example, CD371 in DUX4 rearranged leukemia. But again, ideally to identify all information of clinical and prognostic relevance, a sequencing-based approach is important. Now, what is the importance of detecting this information apart from getting insight into the genetics and biology of these subtypes? Well, firstly, we know that many of these subtypes are associated with outcome, and this is now being seen in both children and adults. So several studies have now been published from many cohorts from St. Jude, from the Children's Oncology Group, from European groups, etc., showing that many of the new subtypes are associated with good and inferior outcome. And notable examples of that are DUX4 rearranged leukemia is associated with favourable outcome, although interestingly, relatively high rates of MRD early in therapy, but then overall good survival rates subsequently. And in addition, some of the newer subtypes are associated with poor outcome. And we know, of course, about pH-like leukemia being associated with poor outcome, but some of the newer subtypes are also associated with poor outcome as well. So then this leads to the second question, which is, what does this mean for patients? Well, the answer here is, of course, the potential for improved outcomes, either by better risk stratification at initial diagnosis and perhaps optimization of conventional therapy during initial treatment, but then also the possibility of improved treatment approaches with novel therapy. And those novel therapies I kind of conceptually group into several areas, those that are truly targeted therapies where one thinks about a therapy directly tackling a mutated gene or a mutated pathway, and kinase inhibitors in pH-like leukemia are a good example of that. Then there are newer approaches that target a vulnerability in a cell that may be induced by the subtype or its driver, but it's not directly targeting the driver itself. And some interesting examples have been seen there, for example, with FAK inhibition in Ikaros mutated leukemia, bromodomain inhibitors, BCL2 inhibitors, particularly in hypodiploid and other subtypes of leukemia. So a number of the new subtypes we're seeing do have potential vulnerabilities that extend beyond conventional targeting of a mutation. And then in addition, there is the opportunity to think about intervening in high-risk leukemia with novel therapy somewhat earlier in the course of disease. So for example, rather than waiting for poor response or treatment failure, one might think about intervening with a novel approach at initial diagnosis before one sees poor response. And that is now being explored by many groups. And the sorts of agents that are being considered there are the BCL2 inhibitors and that family of agents such as venetoclax and navitoclax, and also the immunotherapeutic approaches, including the antibody-based approaches, blinatumomab, inotuzumab, as well as CAR T-cell therapy being given earlier in therapy rather than just considering its use at relapse. And those approaches are now being tested in a variety of different contexts by individual institutions, by cooperative groups, and of course in adults as well as in children. One other aspect I would mention about this, about the role of genomics in understanding the biology of leukemia and what that means for patients, is not just examining genomics at diagnosis, but also during therapy. So we're kind of still largely thinking about genomics based on what happens at initial diagnosis, what the alterations are at day zero before any therapy is administered. But of course, the leukemia in any individual is not static. It typically evolves over time with resistance, driving mutations becoming emergent or acquired during therapy. And so one future area of endeavour that's going to be very important is tracking clonal evolution over time and thinking about what mutations are emerging as potential targets for therapy or modulation of therapy or preemptive therapy. I've spoken mostly about BALL, but genomics are also very important for TALL, although often are not considered so much. And there are several reasons for that. I think one is that TALL is less common. It's much less common than BALL. It's of a ratio of about 4:1. The genomics have not been so widely implemented clinically, and there are generally much less data about subtypes of TALL and outcome. Part of the reason for that is that it is somewhat more difficult to robustly call the subtypes of TALL, for example, often because the drivers are rearrangements, but they're more difficult to detect by conventional RNA sequencing. The rearrangements may break the genome outside of genic regions and not lead to a chimeric fusion transcript. But those data are now starting to emerge. There are larger studies and more studies are emerging looking at the subtypes of TALL, the underlying mutations and their associations with outcome. One example I would give in this space is we are seeing studies emerging now that are moving beyond immunophenotype and starting to break down lineage ambiguous leukemias and identifying individual subtypes of leukemia that include early T-cell precursor leukemia, mixed phenotype acute leukemia, and showing their drivers and their associations with outcome. A recent example of that is a subgroup of patients defined by activating alterations of BCL11B. So the discovery era, I would argue, is not complete yet. There's a lot of work still to be done in clinically annotated cohorts, including whole genome and RNA sequencing. And I will expect over the next few years that will further refine and complete our understanding of the genomics of ALL, both BALL and TALL, and what that means for diagnosis and therapy.
Thank you for listening to the ALL Hub podcast. We would also like to thank our supporters, Novartis and Amgen.
ALL Hub Podcasts, brought to you by Scientific Education Support.